Today we're going to talk about what makes a seizure. I think to a lot of folks, including myself in the past, it's sort of an esoteric phenomenon that almost seems like it's an elusive definition, especially if you're in the monitoring room and you're monitoring several patients and you're unsure, well, is this a seizure? Is it not a seizure? Well, the good news is there are some very clear guidelines that can help you navigate and determine what paroxysms do qualify for seizure activity. In this case, this screenshot, this is a left temporal seizure. Why is it important to identify seizures? What's the big deal about it? Well, it for sure helps guide the treatment pathway. I mean, just beyond the common sense, that you want to know what's causing issues for a patient. There's a ton of evidence from animal models which indicate that seizures which are persistent or prolonged, and those include non-clinical, they can cause neuronal damage and they can exacerbate the initial neurological damage or insult, say a stroke, which itself may have provoked the seizure activity. It burdens the body, including the brain, with increased metabolic demand. It's not a natural process, it's taxing on the physiological mechanisms of the body. It can increase cerebral blood flow, which can also, as a result of that, raise the intracranial pressure, ICP. In many cases, it can offer an explanation for the cause of the patient's altered mental status. Of course, if you have a patient who is not having seizures, uh, the EEG is still helpful because it can let you know, well, they're encephalopathic, that clearly they have a metabolic or some other type of encephalopathy. You can confirm or exclude an epileptic etiology for altered mental status. Now, the data for outcomes of patients with non-clinical, say, electrographic only seizures is mixed, but there is no questioning that there's a ton of evidence which indicate that prolonged seizure activity is not good on this body, on the system. So there are different types of seizures. There are electrographic seizures. We're going to divide them up within this prism. Okay. You can also divide them up between, say, genetic epilepsy, symptomatic epilepsy, but we're just looking at it through the prism of, is it electrographic only? Are we identifying or defining a seizure just based on EEG evidence? Or are we incorporating other domains such as the clinical behavior? So you can have an electrographic seizure that can be focal or generalized, and it can have evolution or it can be without evolution. Without evolution, some examples are, say, LPDs that surpass a frequency threshold of around 2.5 to 3 hertz. So anything that's faster than that points towards it being a seizure. If you have, say, 2.5 to 3 hertz spike in waves, which do not resolve, so they don't just have a burst of, say, 5-second spike in waves, they're just continuous. Well, that in and of itself, that unabating or unresolving activity points towards seizure activity. We can also have electroclinical seizures, and just like electrographic, they can be both focal and generalized. And of course, electroclinical seizures can also have evolution, but they don't have to have evolution, and they don't have to be at least 10 seconds. Some examples of electroclinical seizures without evolution are absence seizures. They don't evolve. They just show up abruptly and then end. Myoclonic seizures, tonic seizures, frontal lobe seizures. A lot of frontal lobe seizures do not show evolution. Infantile and epileptic spasms, GTCs, generalized tonic-clonic seizures. Not always, they don't always have clear evolution. And then LPDs with time-locked clinical correlate. So those are some examples. And the way I like to look at things is we have the water line, so right here, about halfway across this image, And then we have above the waterline, which is the sky, the atmosphere, and then below the waterline. So any bubbles above the waterline are definitively ictal. They are seizure activity, and these include a sustained discharge or series of discharges, a sustained paroxysm. And this is the waterline going about halfway across horizontally. We have above the waterline, which is the atmosphere and sky, and then below the waterline, which is submerged. So above the waterline, we have some examples of definitive seizure activity, which is, for example, a sustained paroxysm with clear evolution. Also, no evolution, but time-locked clinical features to the IEDs. Uh, for example, a myoclonic seizure, an infantile spasm, LPDs, which are time-locked with facial twitching. Those are all definitive seizure activity. Also, no evolution, but greater than or equal to 10 seconds of sustained activity, which is above 2.5 to 3 hertz in that range. Then we have this red submerged region, which are not seizure activity. They're clearly and definitively not ictal. These include LPDs, which of course are below 2.5 hertz, and they do not have any time-locked clinical features. Birds, brief ictal rhythmic discharges, those are less than 10 seconds. They do have evolution, and they do not have any clinical features. So those are not considered seizure activity. Also, a rhythmic paroxysm, say under that 2.5 hertz to 3 hertz threshold and less than 10 seconds with no evolution. And then in the middle, we have this gray area right at the waterline, what we call the ictal interictal continuum. So sometimes you aren't sure. It could be one, it could be the other. Say, for example, activity which is periodic, and it's right at that 2.5 hertz threshold. And maybe we're unsure if there's any clinical accompaniment. Maybe there's a subtle clinical accompaniment, but maybe we can't see that on video. Uh, Also, you might have some discharges. Yeah, they can be greater than 10 seconds, but maybe they don't have clear evolution. Maybe they kind of hesitate, they pause, and then start again. So in the green boxes here, we're going to start with the top box, electrographic seizure. And what do we use for guideposts? What sources, trusted sources, can we use to help us make sense of what can and cannot be seizure activity? Well, there are two very important publications. The first is what's called the Young criteria, and a lot of the attendings historically use this criteria. A more recent addition to the scene is relatively recent, is the ACNS critical care criteria. So both of these really complement each other, and they're very similar in what components they use to define what is an electrographic seizure. As far as electrographic status epilepticus, so non-clinical, we used to say subclinical. We don't say that anymore. But electrographic status epilepticus, or ESE, that is electrographic seizure activity which extends beyond a 10-minute threshold, or seizure activity which is greater than or equal to 20% per hour of recording. So you can either have a definitive, like, compartmentalized seizure, which is over 10 minutes, or you can have, say, several seizures of very brief duration, or sorry, of brief or intermediate duration, but they're happening so frequently that those actually qualify as status epilepticus. We can also have what we talked about, electroclinical seizure. That's where we have some EEG evidence, which is time locked to clinical features. For example, a myoclonic seizure. The duration of the total event is irrelevant for electroclinical seizures. For example, an absence seizure does not have to last 10 seconds, but can have behavioral arrest, say maybe 6, 7 seconds. Infantile spasms are way less than 10 seconds. And then, of course, LPDs, which are time locked to mouth twitching, they don't have evolution, nor are they 10 seconds if you look at the individual discharge, which is causing the twitching. We also have electroclinical status epilepticus, and this is a very uh, well, none of these are good, obviously, but electroclinical or convulsive status epilepticus, that is a very dangerous phenomenon. And I guess you could say that convulsive status epilepticus is one variant of electroclinical status epilepticus, because you might have a patient who is having, say, absence status. Well, that's not convulsive status epilepticus. So convulsive status epilepticus is just one type of electroclinical status epilepticus, but that's any electroclinical seizure activity which is greater than or equal to 10 minutes, the same as the electrographic status, or 20% of each hour of recording. And it also qualifies if you have ongoing seizure, which has bilateral tonic-clonic motor activity, which is equal to or greater than 5 minutes. So if you have bilateral participation that complements the EEG paroxysm, you don't have to wait for that 10-minute threshold. At 5 minutes is considered status, convulsive status in that case. Okay, so we have different ways we can break down what seizures are and defining each variant, each phenotype. Number one, we can assess for sustained activity. And well, first of all, sustained activity is not going to include, say, a myoclonic seizure, an infantile spasm, or LPDs with time-locked clinical twitching, say. Sustained activity is going to be building upon itself. I guess an example of a normal variant for sustained activity would be, say, RMTD. It's kind of an a rhythmic pattern. And sustained activity with evolution is one type, so it builds upon itself, it evolves. But you can also have sustained activity without evolution. It's paroxysmal, and maybe it's above that 2.5 to 3 hertz threshold, or maybe it's just not going away. Say 2.5 hertz spike and wave status. I mean, there's no evolution there, but it's seizure activity. You can also have unsustained activity without evolution, and like we talked about, LPDs with lip twitching, myoclonic seizure, infantile spasms, epileptic spasms. But we'll focus primarily today on discussing the qualifications for seizures with evolution. So electrographic seizures tend to exhibit evolution. Some examples are a left temporal focal seizure without any clear salient clinical features. Also, an example would be a neonatal right central seizure without any clinical accompaniments. If there is time-locked clinical activity, then that electrographic seizure is reclassified as an electroclinical seizure. Here we're going to talk about electrographic seizures with evolution. And just like this series of images shows, there's a gradual evolution, there's a gradual building upon itself with this type of seizure. What I've done here is just try to make a cheat sheet for the ACNS qualifiers for evolution. And they consider at least 2 unequivocal or 2 definitive sequential changes in frequency, morphology, or location. And then they have some sub qualifiers here. You can have evolution in frequency, evolution in morphology, or evolution in location. Say it propagates, or the field spreads to additional electrodes, or sometimes it migrates. It literally moves from one region to another region. But evolution in voltage alone does not qualify for evolution proper, according to ACNS. And what they're trying to say is you don't just have an abrupt transition from a small fire out in a field to a field-wide fire. As you can imagine, there's just a gradual spreading. There's a logical, systematic growth as that fire expands. The same with a seizure with evolution. So it's not just an instantaneous transition. And this can help us distinguish a seizure, an electrographic seizure with evolution from artifact. That's why video is so important. A lot of times, say tapping an electrode or the patient scratching or some other unexplained artifact, a lot of times they can closely mimic authentic cortical activity, right? Electrocortical activity. So then we can say, well, are we seeing any type of logical evolution with this paroxysm? Does the field make sense? And a lot of times the field does not make sense. So an electrographic seizure has a gradual, though steady, sustained increase. So it kind of increases in voltage, the frequency may increase, and then there oftentimes is a deceleration towards the end of the seizure, but it's a gradual transition. According to ACNS criteria for electrographic seizure, I've got a little flow sheet here. Does the activity you're concerned about last for greater than or equal to 10 seconds? No. Stop. It's not an electrographic seizure. Yes. Well, is it 2.5 hertz or above 2.5 hertz? Yes. It's a seizure. No, it's not 2.5 hertz, but it's much longer than 10 seconds. Well, is there clear evolution? Yes, then it's a seizure. The discharges do not have to be epileptiform. Here is a cheat sheet for the Young criteria for seizure, very similar to ACNS. Does the activity last for greater than 10 seconds? No, it's not an electrographic seizure. Yes, are the discharges epileptiform? No, but they are sequential and rhythmic. And then it has you consider these factors. Are all of the first three secondary criteria met? Is there an incrementing onset, say an increase in voltage and or change in frequency, a decrementing offset, say a deceleration in the frequency or decrease in voltage? Well, if the discharges are epileptiform, if we go back a little bit in this pathway, yes, they are epileptiform. It's more than 10 seconds. Well, is the activity greater than 3 hertz? Yes, and then you just look at these criteria. No, and a good example of this no, so if we go from this path down to here, maybe you have a patient who has, say, 2 hertz continuous GPDs. I mean, they're just there constantly. Well, we'll talk about this, what's called a Ativan push test or a benzo test. And if there's improvement, then yes, it's a seizure because those discharges were affecting the patient's alertness and their state of consciousness. But you can see here where I've put these dashed ovals. I'm just showing you that these align with evolution. That's basically what they're saying. So in a nutshell, both the Young criteria and the ACNS critical care guidelines align in essence. And we can infer that at around 2.5 to 3 hertz, there is agreement that this is a very important threshold for what qualifies as an electrographic seizure. They both agree that you need at least 10 seconds, greater than or equal to 10 seconds. They both agree that evolution is required. And they both agree that 2.5 to 3 hertz threshold is very important. But of course, we have those activities oftentimes on EEGs which are not that clear, and that's what we call the interictal continuum. So right here in the leftward green dashed box, say on this side of the purple rectangle, that's clearly a seizure. But as this word ictal starts to fade, we're less convinced. And the same over here with interictal on the far right. So this rightward portion of the purple rectangular box, clearly not a seizure. But then there's activity as this word interictal fades that we're not so sure about. And so there's a gray area, there's a continuum. There are not always discrete partitions between seizure and not seizure. Very similar to quantum states of electrons. Well, it's actually opposite of quantum states of electrons because those do have discrete energy levels, all or nothing. All right, so what can you do like we talked about if you have a patient who has, say, For example, like these GPDs with triphasic morphology, they're not occasional, they're not even abundant, they're continuous. Well, let's see if they're contributing to the patient's altered state of alertness. Now, you can't do this test if you have a patient who is heavily sedated, because more often than not, that's going to be the reason the patient is not properly responsive or oriented. So we have this patient. Well, what we can do, and again, we want to exclude heavily sedated and or paralyzed patients. But what we can do is give a trial of a benzodiazepine, say midazolam, 1 milligram per dose. We start with that. After that first dose, we do another neuro assessment and perform another EEG. Now, let me just say this. Most people, if you give them an IV bolus of Ativan or Versed, their level of alertness, their level of consciousness is going to decrease, right? When you see the counterintuitive opposite response, when you give somebody a bolus of a benzo like this via IV and they improve clinically, well, that tells you that the EEG is likely contributing, the EEG pattern is likely contributing to their altered state of their altered mental function. All right, but you want to stop the trial if the EEG pattern of concern resolves. So if you break them out of that GPD pattern, stop the trial. You also stop the trial if there's clear clinical improvement, because as I said, typically you would expect a decrease in the patient's level of consciousness. If they are now talking to you and more oriented, then this is suggesting whatever pattern that was causing was affecting their mental state. You also want to stop the trial if adverse effects are observed, including respiratory depression, hypotension, or some other adverse effect not specified here. You also want to stop once you've reached a maximum dose of the benzo, whatever that may be. I don't know what that is. Maybe 4 milligrams, but I'm not sure. A positive test for seizure activity includes you break the pattern and either one of these. So you break the pattern and there's an improvement in their clinical state, or break the pattern and now you're seeing some normal EEG patterns, say like the PDR, patterns that were not there previously. If the EEG improves but the patient does not, it's equivocal. So interictal continuum. This is from an article, a research paper, where they looked at a set of patients, a series of patients who had continuous GPDs with triphasic morphology. Here's the source down here at the bottom if you would like to look at it yourself. So they considered seizure activity, or they defined seizure activity to be, one, there was resolution of the EEG pattern, so the GPDs with triphasic morphology, and either one of the two following. There was improvement in their mental state or their encephalopathic presence, or there was appearance of the previously absent normal EEG activity. So this is very similar to this previous page, which Larry Hirsch, Dr. Hirsch, published. So it is a seizure if yes to one and yes to either two or three. And our physicians do this test from time to time, or at the least, they recommend doing this test in the clinical correlation of the EEG report. Okay, so in this particular study, there were 64 patients. 18.9% of the patients who were given benzo had a positive clinical response, so they proved it was a seizure. 42.2% were given a non-sedation AED, perhaps Capra, something like that. But the cumulative percentage of efficacy for this push test was 34.4%. So there was a 34.4% proportion of those 64 patients who actually improved clinically after being given these medications. So let's briefly talk about BIRDs, brief ictal rhythmic discharges, sort of a misnomer because ictal is in the acronym and they're not considered ictal. But ACNS considers BIRDs to be greater than 4 hertz for at least 6 repeating waves. And you want to have around the same frequency. Of course, there can be evolution. And the duration is greater than or equal to 0.5 seconds up to less than 10 seconds. So maybe up to 9.5 seconds, something like that. BIRDs is not, the pattern does not align with BIRDs if it is a component of burst suppression. If it's a normal, obviously, if it's a normal variant or pattern, or if there is a clinical time-locked correlate, because immediately, if there is, that qualifies for electroclinical seizure activity. If at any time the EEG pattern, paroxysm, affects the patient's mental state or their body, if there's a direct correlation, it's immediately, inherently seizure activity. So BIRDs, definitive BIRDs, are going to have at least one of the following: evolution, and if they do, we call those evolving BIRDs, or a similar morphology and field presence to the patient's interictal IEDs or seizures. Say they have right temporal spikes. Then if the BIRDs, or the pattern that you're trying to qualify for BIRDs, has spiky activity, but it's just more sustained, right? Maybe it's lasting for 6 seconds. If it's in that same region, then that's definitive BIRDs. Possible BIRDs, they're sharply contoured, though they don't have evolution, or they're not similar to the patient's interictal epileptiform discharges. Here's an example of BIRDs. Upon first inspection, well, at least myself, I would say, oh, is this a young patient and their sleep spindles are just not synchronized yet? Because a lot of times younger patients have these archiform U-like appearance or morphology of their spindles. These are definitive BIRDs. These are definitely BIRDs. You can see the spindles actually are here. They're lower voltage and they're bicentrally represented. But in the left frontopolar region, we see some BIRDs right here. And here's another example of BIRDs in the midline central and right parasagittal region. Thirdly, let's look at our third example of BIRDs over here in the right hemisphere. Now, this paroxysm lasts for 6 seconds, so it's not a seizure. Let's do a checklist for BIRDs. Is it greater than 4 hertz? It is greater than 4 hertz. It starts out at about 9 hertz. Are there at least 6 waves at a regular rate? Yes, there are. Is the burst between 0.5 seconds and up to or less than 10 seconds? Yes. It's not a part of burst suppression. We're going to assume there's no clinical correlate, which there was not. And does it have one of the following? Does it have evolution? Well, yes, it does have evolution. There is a change in the amplitude. In addition to that, it actually speeds up. It's more like 10 hertz towards the end of the paroxysm. And we can always kind of just refer back to that. And we're not sure, just based on this one screenshot, if this pattern is similar to the morphology and location as that patient's IEDs or seizures. But I can tell you, I remember this patient, they actually were. So in this case, these are definitive seizures. Oh, pardon me, definitive BIRDs, not definitive seizures. They are not possible, they are definitive. At the same time, while we're incorporating and utilizing the ACNS guidelines, the Young criteria, we also want to use some informed discretion. We want to have a little caveat in the back of our mind. to avoid overly rigid parameters. It says basically it's a challenge to establish rigid, specific criteria for electrographic seizures due to the high variability that we see in the ICU population. But in general, we expect a gradual increase or decrease in the frequency of the EEG pattern, and we expect to see a spread or field propagation to a greater number of electrodes. Electrographic seizures tend to have an amplitude that is larger or of higher magnitude than the patient's baseline EEG amplitude. So it's paroxysmal by definition. And it shows evolution in frequency and spatial distribution. And also you can see that important 10-second threshold is mentioned here as well. So that's three sources that are utilizing that 10-second threshold. Okay, here's an example of absence status. And what I wanted to convey to you here is we have status epilepticus. And in this case, it was clinical status epilepticus. It wasn't convulsive status epilepticus, a generalized status. But you can see that there's no evolution and there's not sustained activity. It actually pauses and restarts. But I've compressed the time base here. So you can see 3 seconds is represented to where normally 1 second is represented. And this patient was in absence status for a long time, a relatively long time. I would say greater than an hour. And interestingly, you can watch the video at times during one of these bursts, a bedside caregiver will ask the patient a question to test their alertness, and they would be able to answer them. Like, what is your first and last name? They asked that question during a burst, correct. But it wasn't consistent. There were other times where they were just non-responsive. So if there's any unresponsiveness, which is time locked to such activity, then it's inherently ictal. In addition to that, it was so persistent, it took up such a large proportion of the patient, say well over 20%, right, per hour. Now, here's an example of electrographic status epilepticus. In similar spirit to the last slide with absence status, this also is conveying to you that a patient can be in status, but there's not just continual seizure activity. It's not continuous. If there's activity, which is ictal, which is greater than 20% per of every hour, so 12 minutes of every hour, at least 12 minutes in seizure activity, then that's considered status. So if you have a patient who's having just a ton of focal seizures or a ton of generalized seizures, by definition, because of the frequency, the abundance of those recurring seizures, that qualifies for status epilepticus. This particular patient had right focal seizures. And I'm just going to zoom in here and show you the FFT spectrogram and the rhythmicity spectrogram. And within our view, we can actually see two different seizures. Here's the first one. And I've got this pink dashed arrow pointing downward to indicate to you that across time, or as the x-axis as we move from left to right, the most active frequency bands, this yellow and the green, decrease. There's a downward slope, so there's deceleration, which is one of the features of evolution. We can also see that within the same seizure at the same time in the rhythmicity spectrogram. You can see how there's a nice, gentle deceleration across time as this seizure activity slows down, as the frequency gently decreases, gently though consistently. And the second upward pinkish dashed arrow is actually part of the same seizure. So maybe I should have just drawn or overlaid a dashed arrow pointing down that was this whole thing, because these are actually the same seizure. We have a second seizure here, and then you can see how it's conveyed within the rhythmicity spectrogram. This is the same patient, though here we have a 30-minute epoch. And let's see how many seizures. Let's count the number of seizures. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then I counted how many of these were marked as seizures, and I said, oh, I missed one. And this one right here is actually a discrete separate seizure, is in status. Here's another patient. And we're going to show you a seizure. This is a focal seizure. And what I want to convey here is that not all seizures, in particularly the onset, not all seizures have a clear, drastic, easily apparent visual cue that the seizure has started. And a lot of times with neonate patients who have seizures, as well as within the ICU population, you do have this insidious, gradual evolution, which is in the delta band. And if you're just looking from one page to the next, it's hard to tell that there's evolution. So if we zoom ahead in time to several epochs later, this is just where we're at now. It's just almost, you can't tell that you've aged from yesterday to today. But if you were to compare from yesterday to a year from now, there is a gradual incremental change. It's just hard to see going from one page to the next. And this is just a portion of the seizure on the left. And you can see there's evolution in the morphology, right? They did not look like that initially. So they now have a spike and wave appearance. On the right, the persist, the quantitative EEG, anywhere where you see that red shading, I'm not talking about the seizure probability up here, I'm talking about the asymmetry relative spectrogram. Or if you see that red shading, that's telling you that really from like 2 hertz all the way up to 20 hertz, the red hemisphere was dominating the scene. So this is showing you this seizure lasted for several minutes, and it just had this gradual, insidious evolution to it. This is another example, I believe. Let me just double check here. Oops. Yeah, this is a different patient. I just wanted to make sure I was telling you the right thing. Okay, so now we're looking at a new patient. Pay attention to the right temporal chain. Now, we do have to consider that the right temporal chain is just at baseline different from the left, which it is in this case. There's this delta slowing that we're seeing. But when I compress the time base to 15 millimeters per second, which is really helpful when you're assessing for these types of paroxysms, which are in the delta range, you're able to zoom out. I like to use the analogy of a roller coaster. If you're right up in person and you're looking up at a roller coaster, you might just see one portion of how that track is contoured. But if you back up, say, 1,000 yards or whatever, now you can see the whole ups and downs and curves of the roller coaster. But we have another example of an insidious, deceptive appearance of evolution here, which we can see with both neonates and a lot of times in the ICU population. Not exclusive to those patient populations, but a lot of times that's where you'll see them. So here's the approximate onset time of this electrographic seizure. If I'm looking at this EEG, there's no way that I can tell a difference from this first 4 or 5 seconds to the following 6 seconds. But if I decrease the time base and move forward just a bit in the record during the seizure, now we can see that delta, rhythmic delta is sustained, and we can see how it's evolving, accelerating, speeding up. And this is that same patient. And now we're looking at persist or the quantitative EEG. And if you're intimidated, please don't be, because it's like so many things in life, we make things more complicated than they are upon first inspection. So if you see this real heavy shading right here in the left, I've chosen F7T3 because that's where the seizure was localized to. That's a seizure. Over the right, I chose T4, T6 because that's where it was maximal. That's a seizure. See the slope, how it's going down? Right here, that's a feature of evolution. Now over the left, we have a slope going upwards. That's that seizure accelerating. And we saw that, how it accelerated from the delta band, right? Here's another over the right, left. These are bilaterally independent focal electrographic seizures. And the point of me including these examples was to show you that evolution need not be so apparent. Sometimes it can take a long time. But you want to think of an electrographic seizure as activity that builds upon itself. What comes next is confined or burdened to be what came before it. It's a result of what came before it. We're a product of our environment. You've heard that. Well, the next wave that's coming in this seizure is going to be affected by the one before it. They're all similar. So think of it as building upon itself. So here you have a drummer. We're going to measure the intensity of the drum stroke. Very subtle, but every time he uses the drums, it's a little bit faster. And if you look at the meter here measuring the intensity, it's a little bit stronger. It's gradual but consistent buildup. So across time, this is just showing you, this is an analogy for evolution. That's the point. And I'm looking at this and I'm seeing these LPDs. They have a sharp contour. And if I were to assign a modifier to these, I would say they have superimposed fast activity, almost like spindles, which are time locked to the LPD proper. And plus F is superimposed fast activity. But if you look here, over the right, parasagittal, we see LPDs. But this is why LPDs inherently are indicative of hypercortical excitability, because they're almost like a little spark that's constantly firing. Say your grill, you push the button when you see a little blue spark, 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 spark. Well, that spark could catch fire and actually transition into a seizure where it grows upon itself, similar to an ember. If you have an ember that's just sitting there, if it catches fire, the ember is the initial catalyst of that particular fire. Not all seizures are like that. Not all seizures begin with LPDs, but they can. Now, notice here, the LPDs, they look a little bit different, but we still have sort of this 1 to 2 second post-discharge attenuation. This looks different. I think what we see is an electrographic seizure. We have the onset. Initial frequency is around 2 hertz. There's an increase in voltage. It's building upon itself. There's an increase in frequency. And oftentimes, whether or not the patient's going to have any clinical features which accompany the EEG seizure is the seizure occurring on the patient's dominant hemisphere. That's why you can have a patient with temporal lobe seizures and they can talk to you and they don't have any type of aphasia. Well, that's probably because it's on the non-dominant hemisphere. I like to say that a focal seizure like that, a temporal lobe seizure, is sort of a quote unquote a poor man's WADA, because you can see with the video EEG during a seizure that patient is not responding to you. They can't talk. It's because that portion of the brain is affected, analogous to if you introduce, say sodium amytal or propofol. All right, so that's an example of LPDs which transition into an electrographic seizure. So intuition is important. And like I mentioned a few slides ago, we want to avoid rigidly confining our criteria for defining, say, a seizure which is qualified by the presence of evolution, because the published criteria isn't itself totally exact. But we can see there's a sort of, we're in the right church, but maybe there's different pews we can sit at. We can approximate really well what is typically a seizure and what is not a seizure. And notably in the context of the coexisting ictal interictal continuum. But these publications that we use so much, like the ACNS critical care guidelines, as well as the Young criteria, they are so helpful. They provide a framework for you to define seizure. When you're in that EEG monitoring room, there are checklists available, and these can sometimes make that esoteric or elusive. That's the way I used to feel. Like, well, what are they calling a seizure? Well, you can actually quantify it. You can break it down systematically and logically and make it a lot smaller bite-sized pieces. But is it sustained? Does it grow, quote unquote? Does it spread? And are these rhetorical questions? Yep. So an electroclinical seizure, or ECS, does not, as we talked about, it does not have to be 10 seconds in duration. If you have time-locked clinical activity during the paroxysm, then immediately it's a seizure. It's considered ictal. Here's some examples for you. LPDs, which are time-locked to focal motor phenomena, say maybe a finger twitching, a baby who their right leg is jerking and they have left central LPDs, lip twitching, but also generalized 3 hertz spiking waves with time-locked behavioral arrest, or they can be less than 3 hertz. If they are time-locked to behavioral arrest, seizure, seizure, seizure. Doesn't have to be 10 seconds. Epileptic spasms are inherently ictal, even though they're nowhere near 10 seconds. Same with myoclonic seizures. So here's a patient who unfortunately suffered a rather widespread stroke, as you can see over the left, all this dark shading in the MRI. Well, the stroke was the reason they developed these left parasagittal or left frontocentral LPDs. And what's really interesting, if you can use the word for a patient, because it's never fortunate circumstance, but what's helpful here as far as from a learning prism and interesting in that aspect is I actually did this. I actually watched the video and I marked every time this patient had their right upper lip twitch. So there's a little bit of a lag from the onset of each LPD to when there was an observable twitch. And the F3 maximal phase reversal that you see here, that you see here, that's separate than the LPD. That's actually part of that lip twitching right there. That's the LPD. So, and then again, if we consider this LPD proper right here, this right here is actually EMG artifacts. That's the first sign of clinical time-locked correlate. I measured it, it's 50 hertz. It lined up with the video. So this is an example of seizure activity. And technically, it's status, it's focal status, because this patient was constantly like this. They were in focal status, clinical status. If we look at the homunculus and incorporate that while we're looking at these LPDs, which are maximal in the left frontocentral region, we can see that if FZ and CZ are right here at the top, and T7 or T3 is way down here, about halfway from those electrodes to the other is the appearance or location of F3 and C3 along the transverse plane, right? And what do we have right there in the frontal lobe? We have the motor region for the lips. Well, his right lip, or the upper right portion of his lip, was twitching because these discharges were firing on the left side and they were provoking movement on the contralateral side of the body. So there's an LPD. That's actually movement artifact. And that's EMG time locked artifact, which is caused by the LPD. It happens just a little bit before the actual twitch artifact. But an electroclinical seizure is when you have an EEG paroxysm, which is time locked to clinical features. The duration of the event is irrelevant. For example, absence seizures, LPDs, like we just looked at. Here's another example of an electroclinical seizure, which is less than 10 seconds. This is a classic HB provoked 3 hertz spike and wave absence seizure. So there's the onset. With behavioral arrest, they stopped blowing the pinwheel, and there's the end. Definitely less than 10 seconds. Nonetheless, it's a seizure. I think I measured it to be 7.8 seconds, so almost 8 seconds. Here's another example of electroclinical seizure activity, and these are myoclonic seizures. If you'll note the sensitivity, so it's actually decreased quite a bit. So that's 400 microvolts. I don't remember exactly what the setting was, but I guess we could calculate it if we needed to. So there were time-locked jerks to each one of these paroxysms you see here. So that's technically status, myoclonic status. They were having a myoclonic seizure every time you saw one of these discharges. Now here's a tonic seizure, which starts about right here. So prior to the seizure onset, looks like we have into sleep with vertex waves, sleep spindles. And now, right about here, we have an electrodecrement with simultaneous appearance of these faster waves. That's not muscle, that's actually faster beta activities. And in the quantitative EEG window right here, every time you see, for example, within the rhythmicity spectrogram, every time you see this sort of dark blue shading, that's a seizure, that's another seizure, that's another seizure. So these don't have evolution, right? But they're still seizures. And this is the next epoch, or the next EEG page from that last tonic seizure. There's a lot of beta. Now, it is very important to keep in mind, everybody, that you can have a patient who is having some clinical abnormality, say their fingers twitching or their eyelids twitching, or like a very confined portion of their body is not behaving normally. The minimum detection threshold for surface EEG is anywhere from 6 to 10 centimeters squared. So if a patient could be having a seizure, and it happens, which is less than that threshold, and say if it lies on the motor strip, or say if it lies right on the sensory strip, they're going to be sensing something, but we won't see anything on EEG because it's less than this. Right here, I have it just to show you the surface area. Of course, you could rearrange this rectangular box to be any shape as long as the surface area was the same. But we always want to keep that in mind, that surface EEG has a detection limit, a lower threshold. Now, this is not talking about intracranial EEG because it doesn't have the skull, the meninges, and the blood products to attenuate that signal. So a lot of times in reports, you'll see mention of the caveat. However, the possibility of focal seizures without surface EEG correlate is possible. This is the reason. There are 2 articles. The first, 1965, is the classic. It says 6 centimeters squared. The more relatively recent, by Tao in 2005, says 10. So 6 to 10. Frontal lobe seizures also oftentimes don't have that, say, classic evolutionary nature to them, or the EEG correlate. And one of the reasons is because a lot of there's different phenotypes, there's different variants of frontal lobe seizures, of course. But the ones that you see where patients immediately jump out of sleep and they have this like arrhythmic pedaling motion, and they're oftentimes occurring deeper in the cortex. So we're not going to have a surface EEG correlate. So it can either be that the portion of the cortex which is causing this electrographic seizure or causing the seizure is below 6 to 10 centimeters squared, or it could be that it's not below 10 centimeters squared, but it's just so deep in the cortex that we're not seeing that much. So with frontal lobe seizures, you certainly have high frequency beta, at least beta activity that's happening. But as you may know, faster frequencies are much more attenuated by the skull, the meninges, the blood products than slower frequencies. It's one of the reasons we have the posterior to anterior amplitude and frequency gradient. Not the only reason, but slower waves are going to be shown or detected more readily with surface EEG. Can be but beyond the detection of scalp electrodes. And so a lot of times when we think we're saying, oh, that's an electrodecrement, it might be the case that the seizure is in the gamma or beta range in the surface EEG. It's just not able to convey that. So as we just talked about, focal seizures may not be detected with standard surface EEG. This was a very interesting research study performed, and they looked at focal aware seizures, which we used to call simple partial seizures. That term has been obsoleted. So of 87 focal aware seizures that arose from 14 patients, 21 were detected with our standard array of EEG placement. So our 10, 20, 25 to 27 electrode. Between 23 and 27 eye leads or T1, T2. So that means 79% were not detected with surface EEG. 27 of those 87 seizures were motor. And even though there was a motor clinical correlate, there were only 33% of the EEG accompaniment showed a time lock change. 60 of those 87 seizures were non-motor, and only 15% showed a correlate on the EEG. So keep in mind that they had additional electrodes on these patients, but they're only considering what we typically put on our patients, say in the ER, and then they're comparing that to the actual number they put on the patient. And what they found was of 77 focal aware seizures from 13 patients, one was excluded, 61% were detected with surface EEG when they added a few more electrodes. In particular, they tended to try to add those additional electrodes to areas which were likely to be hyperactive, say near a stroke, near a brain tumor, neoplasm. Perhaps that patient had some interictal discharges in that region, so you put a couple of more electrodes there. So that's a relatively high percentage. With the few extra electrodes, they were able to detect 61%. Only 9 out of 77 seizures associated with EEG changes had activity confined just to the additional electrodes. So adding the additional electrodes sort of complemented what was already there, which may have been undetected. But adding those sort of changed the viewing prism of the EEG you were looking at before. 70% of those seizures with surface EEG changes were motor. Very interesting article. As we talked about, deeper frontal lobe seizures may not be detected. Well, we detect the artifact, the movement artifact. But you know what else we detect? We detect the abrupt transition from, say, N2 or N3 sleep to a relative electrodecrement, right? Not a decrement proper, but the background drastically changes from a sleep normal to this awake, and in this case, ictal activity. So if you see a patient and they're having this clinical behavior and you're like, God, that looks like an NEE, and a lot of the frontal lobe seizures do, patients with NEEs, psychogenic events, they're not able to abruptly transition from deep sleep to the onset of one of their non-epileptic events. So if there's an event that abruptly begins out of sleep in 1 or N2, and I presume N3, even though I don't have that here, even though it has an unorthodox semiology, which might make you suspicious for non-epileptic event, like pedaling, chaotic movements, the bite is not rhythmic, it's not like quote unquote the pretty expected pattern of a generalized tonic-clonic seizure, it's very likely that it is a seizure. And question, why does it almost entirely exclude the possibility of that being a non-epileptic event? It's because of the abrupt transition out of sleep. A cat, say the sleeping cat's not just going to go from sleeping to bouncing around chasing flies. There's a process. So that's mutually exclusive with the psychogenic non-epileptic event. Here's a frontal lobe seizure, and if somebody were to ask me, and I, for some reason, did not know about this abrupt transition that you can have with frontal lobe seizures from into sleep, I'd say, oh, that's a movement artifact. It's an arousal, you know, whatever, they heard something. But this was a confirmed frontal lobe electroclinical seizure. You can see the vertex waves here, sleep spindles, and then this abrupt change, and then you can see all this movement artifact. That's the onset right there. So you can see some transcending themes. Remember, we talked about electrographic seizures with evolution. You don't have just an ember instantaneously changing to a field full of fire. You don't have with frontal lobe seizures, or pardon me, with non-epileptic psychogenic events, you don't have a patient who's into sleep simultaneously just, start having one of their events.